Okay, everyone, welcome back. Today we have someone famous in the IC world. I'm really excited to just talk about all things public health with her. So today we have Nicole Cozean with us. Welcome to the show, Nicole. I'm so sorry I've been mispronouncing your last name for 3 years.
Oh, join the club. That's okay. Callie, thanks so much for having me. I'm really appreciative of you reaching out. We've been sort of been contacting each other on Instagram for a long time now, so I'm glad we're actually finally able to make this happen.
I know. At first I was fangirling and then I was like, you know what? I feel like you'd be great to have on the podcast. So thanks for, giving me an hour of your time. This is going to be a really good conversation.
Yeah, excited.
So, before we dive into all the good stuff, would you mind introducing yourself to the audience?
Yeah, sure thing. So, my name's Dr. Nicole Cozean. I'm a pelvic floor physical therapist. I have a brick and mortar practice called Pelvic Sanity in Orange County, California. And for those of you listening who aren't familiar with Cali, that is about halfway between Los Angeles and San Diego. I've been a pelvic PT for almost 20 years now. I got into pelvic PT right out of PT school, which is actually not that common of a path. At least it wasn't back then. It's actually becoming more common to do that now. But back then, I was still that kind of weirdo person who was super interested in the pelvic floor. And kind of got dragged into it with my first job. And I ended up loving the community and loving helping people get better. I saw a lot of positive results, kind of contrary to what the doom and gloom was on the internet at the time, and a little bit of what that still looks like. And one of the things that got me to treat interstitial cystitis super early in my career was that at the hospital program that I started in Orange County, the pelvic floor program, I was paired up with a urogynecologist who at the time was treating a ton of really complex pelvic pain patients, including interstitial cystitis, but also things like neuralgia, endometriosis. And so I was hooked up with him and I was seeing some of the most complex patients from the start. And that kind of got me into the world of interstitial cystitis. And I was actually seeing, with my approach being very orthopedic in nature, and for all of you listening, that means that we treat outside of the pelvis, including the pelvic floor from the internal perspective. We can get into that here in a little bit as we talk, Callie. I'm sure you have questions about that. But I was taking a very orthopedic approach to these patients with pelvic floor dysfunction causing interstitial cystitis. And I found really great results. And I would go online because I was new at the time trying to learn about this condition. I was going hand in hand with this urogynecologist, and everything that I was seeing with him and seeing with my patients was very different than what I was seeing online. And fast forward now, however many 20 almost 20 years, I now have my own practice. We have a remote consultation and a out of town program where we see patients from all over the world. I train PTs now in interstitial cystitis methods on how to best help people. We have a Finding Pelvic Sanity podcast. We just have so much stuff that's centered around providing hope that healing from interstitial cystitis is not only possible, but it's probable with the right medical team. And so that's sort of been my mission for a really long time, being a pelvic floor therapist.
I just want to say, hell yes. Sorry for cursing, but like when I am in certain like Facebook groups or Reddit threads, there's so much like doom and gloom and like people who don't understand that you can get better and you can get relief. Maybe you may not reach remission and it may not 100% go away, but you can make significant improvements in your symptoms. You can get your quality of life back. Like it is possible. And I think that was one of the most important mindset shifts that I made on my IC journey was going from being really pessimistic about the future, like I'm never going to be able to have a good relationship or travel the world or do whatever, all the dreams that I had growing up. And when I I don't know. I think I just hit rock bottom one day and was like, I have to make a change. Like something has got to give here. And I was like, I'm going to start telling myself, I think my therapist actually told me this, you should start just speaking it into existence. Like tell yourself you can get better and surround yourself with people who support that mindset. And sometimes when you're in these groups, it's like not everybody has that same mindset and it can really bring you down. So that's my
Yeah,
two cents about this.
absolutely. Well, and I'll just say one more piggyback on that. I think, it's a blessing and a curse, right? I mean, I feel like it's super important to know that you're not alone and to know that these symptoms of IC, someone else is also feeling that way. It can be very isolating. So in that way, I think the community of it can be helpful. But, and this is a huge but, you're so right with that you have to surround yourself with people that have that growth mindset that you can change things, that there is an answer out there. And I know as a person that has a chronic illness, like that can get exhausting, but we need to realize that that's the sandbox we're playing in when we're online. It should be we're getting information, we're getting a different approach, we're getting different answers. And then when we find something that's working or that a person that you trust, then it's okay to sort of remove yourself. And then I would love for people to enter back in once they've sort of gotten to the other side and then putting those positive places out. Because at the end, what I tell my patients a lot of times when I'm actually prescribing, like, no Facebook groups, no internet for a short period of time, like it just is not going to serve you well right now. Like you're in the right place with us. Like, let's just hang out here for a second and then we're going to work on nervous system regulation. We're going to work on pelvic floor calming. We're going to do all the things and you can go back once you're on the other side to spread some positivity. But I think that it's a real challenge to play both of those sides. But there have been plenty of times when I have literally written down on a prescription pad that I've made up to be like, no Facebook groups right now, because it doesn't serve you well once you're in the hands of like really good care.
Yeah, because I get it. A lot of people are desperate and they will try literally anything, and that can be dangerous. And I just a couple weeks ago released an episode with Laura Santuri of the ICA, and we were talking about how to decipher like claims that are being made in these groups, how to know if it's evidence based. So if anybody missed that episode, definitely go back and listen. It was a really good one. But yeah, just I guess I didn't expect to talk about this topic, but go into these groups with a grain of salt. If it's toxic to your mindset and your mental health, take a break.
Yes, 1000%. Highly agree.
Yeah, okay. So moving on to IC and pelvic floor dysfunction and their overlap. So I've had a lot of pelvic floor physical therapists on the show before, and we've talked about pelvic floor dysfunction, but I thought it might be helpful to review what the similarities and differences are between interstitial cystitis and pelvic floor dysfunction. So can you take the audience through that?
Yeah, absolutely. So and I know this can be so confusing because you're hearing like, what do I have? Like, I don't really get it. Do I have one or do I have the other? Do I have both? Like, what's going on? So let's start with what the actual definition of interstitial cystitis is, right? So I'm sure your listeners know this, but it begs going over again. So interstitial cystitis or slash bladder pain syndrome, as it's now known, is basically two main things. You have to have something with pelvic pain, so some sort of painful symptom. And I would even go so far as to say that even being uncomfortable because of urgency or anything like that can be construed as pain. So, in the broad scheme of things, I would say that it doesn't have to be like, oh, ouch, I'm hurting all the time, but even something that's very uncomfortable, something that you can't ignore, something that is taking up space in your brain could be considered sort of pain or discomfort. So, pain or discomfort in the pelvis and bladder symptoms. So typically it's urgency, frequency of urination. So urgency meaning I have to go all the time. I feel like I have to go all the time. The urge is for me to go is really strong. That can be with or without actually peeing a lot, right? So you can go to the bathroom a lot. So that's frequency. So urgency, frequency of urination, and pelvic pain. Once you have those two things, and you know it's not a UTI or some other big bladder problem, then you can get diagnosed with interstitial cystitis. And so you don't have to have a cystoscopy. You don't have to have any other testing. You basically just have to have the absence of an other identifiable cause, is what they call it. And I put that in air quotes, right? So, but it specifically states that you don't have to have a cystoscopy to get diagnosed. So that's what ICBPS technically is in the urology world. Now let's go to pelvic floor dysfunction. So pelvic floor dysfunction is essentially a broad term that means that your pelvic floor muscles, in this case, or in most cases, are overly tense or tight. Um, the issue around this for people with interstitial cystitis or bladder symptoms is that pelvic floor dysfunction in and of itself can cause urinary urgency, urinary frequency, pelvic pain. Okay, so now that we know that pelvic floor dysfunction can cause all of the symptoms of IC, we know that you don't have to go, as long as you don't have an infection, then you can get diagnosed with interstitial cystitis. Now all of a sudden the waters get a little bit muddied with what do I really have? And so what we know from the research though is that almost 90% of people that have been diagnosed with interstitial cystitis bladder pain syndrome have some form of pelvic floor dysfunction. So my whole battle cry essentially for you all with IC is to not worry so much about what it's called, but address the pelvic floor dysfunction if you have it, and most of you do, right? And so because regardless of whether you call it IC or pelvic floor dysfunction, the pelvic floor is certainly involved. And so that is sort of like base camp of where you need to be in order to figure out how we're going to address all of these other symptoms. In addition, pelvic floor dysfunction can cause a lot of the other things that y'all have, but that you don't really think about being a pelvic floor issue: back pain, hip pain, tailbone pain, constipation, IBS symptoms, um, abdominal pain, foot pain, sciatic nerve irritation, mid back pain. All of those things can also be caused by pelvic floor dysfunction. And so at the end of the day, I I understand the need and the want to figure out what is this problem. But if we understand that ICBPS is really a symptom, they call it a heterogeneous symptom cluster, right? So it means it's like a lot of different things that are causing this one output, which is urgency, frequency, and pelvic pain. And so if we look at it like that, and we look at the things that we can do about it, which is go to pelvic floor PT, and get the pelvic floor dysfunction addressed, then we're starting to address the thing that's causing the IC symptoms. Now I'm going to pause. Callie, what do you got? Do you have
Yes. So,
questions
okay.
about that?
Yes. So I asked this question to Dr. Moldman when he was on, but I want to hear your take on it. Do you think a lot of people with IC and IC diagnosis really just have pelvic floor dysfunction and are misdiagnosed?
Misdiagnosed. I would say, I mean, my short answer is yes, right? My short answer is yes. And so, but technically, I guess the point is that technically they're not misdiagnosed because the definition and the diagnosis is exactly describing pelvic floor dysfunction. So we're in like a little loop, like a feedback loop, right? So it's not that they're misdiagnosed. I would just say that we tend to think of it as a bladder problem when it actually, for the vast majority of people, it is not. And I know that that can be so hard for people to hear because you're like, well, I have only bladder symptoms or mostly bladder symptoms, and it's so severe and it's debilitating my life. And how could it not be my bladder? And the
Right.
reality is that it's because anatomy and physiology, like once you understand that part, it makes total sense. Your bladder sits right on top of pelvic floor muscles. And I always say this. So if it's almost like the bladder's sitting on this nice little pad of muscle, and if that muscle is mad, that muscle that's tense or tight basically knocks on the bladder and is like, hey, there's a problem here. And the bladder only knows two things. It's either I have to pee, or it sends a message up to the brain is like, pay attention to me. I hurt. Those are the two things it knows how to do. And so we have to really look and see if you have symptoms of interstitial cystitis, which is urinary urgency frequency and or pelvic pain, then we've got to look at why that's happening and what's sending those messages to the bladder. So I sometimes will say it's either the bottom up, meaning it's the pelvic floor and the pudendal nerve sending signals up to the bladder to say I hurt or I have to pee, and or it can also be what I call top down. So because the bladder and peeing in general is controlled by a lot of the autonomic nervous system, which is the nervous system that's just automatic, it's just running in the background. It's why we don't have to think about peeing under normal circumstances. We can just be like, oh, I have to go. And then we go sit on a toilet and it just starts to come out. That whole process is a nervous system process that is really sensitive and directly related to your fight, flight, freeze nervous system. So the sympathetic nervous system and your parasympathetic nervous system. And because of that, there's things like stress and past trauma and stuff like that that can essentially prime your pelvic floor and bladder to be more sensitive to inputs. It's like a sensitive car alarm. Like we could all be sitting where we're listening to this podcast right now and hear a car alarm go off outside. And most of us, unless we're in a really dangerous area, we're not thinking, oh, someone's car's getting stolen. We're like, oh, that stupid car alarm is hypersensitive and going off because someone just brushed by, right? That's essentially what's happening in your pelvic floor and your bladder. And so if we're gonna help people with this condition, then it's bladder's just the echoing chamber. It's not the actual reason why the car alarm's going off in the first place. And that's like my really big, I hope everybody that listens to this podcast takes that away, is that the bladder I see is essentially the symptom, and we need to figure out what's causing the bladder to be talking to us and helping us to pay attention to it. And that's what we need to treat. So in our place, we treat the pelvic floor, we treat the nervous system, we treat the inflammation, we treat all of those things that can create that hypersensitive car alarm in the bladder. And that's what we're really focusing on, and that's where we can get to the root cause. And when we start to really ask, like, well, why is the pelvic floor like that? If the pelvic floor is creating the bladder symptom, then why is the pelvic floor like that? And my big thing at pelvic sanity is to constantly ask why. Well, why is that like that? Well, it's because maybe it's some hip muscles. Well, why is your hip like that? Well, it's from an old injury. Well, why is it hurting like that? Why is your sacroiliac joint moving like that? And now we can start to really unpack some of those underlying reasons why your pelvic floor is a problem and why that might be causing your bladder symptoms.
Yeah, I'm constantly.
And that's true for like 90%. I would even go so far as to say 95%. There's some research studies coming out relatively recent that show that people that have true bladder lining problems, right, which is Hunner's lesions in the bladder. We used to say it was less than 10%, but if you're under the age of 50, it's actually even less likely. So it's like 4%. Over the age under the age of 50, it's only 4% that you have Hunner's lesions. And so that's why, from a pelvic floor PT perspective, we're just like operating under the assumption that most people don't have true bladder lining problem and they also have pelvic floor dysfunction. And if that's the case, then the first line of defense is getting to a pelvic floor physical therapist.
Yeah. Absolutely. Definitely in agreement of like finding the root cause. I'm constantly saying that. I don't love the term root cause, but like it's the most accurate thing to describe
Right.
it.
We say find the why of pelvic sanity. Like, why is it doing that? I don't love, I don't love the phrase root cause either because I feel like it makes it seem like there's one thing. And I think that when you have a multifactorial problem, there's the great news about that is that there's multiple ways to intervene. And that's where I get so excited to help people with interstitial cystitis because there's inflammation, there's nervous system, there's pelvic floor, there's orthopedic things like your hip and your low back and your tailbone, there's all kinds of stuff. And when we can have more choices to intervene, that means there's more chances for us to impact the symptoms in a different way, right? It's not the one thing that's going to be able to quote cure everything. It's that it's a lot of little things that's going to eventually lead to that probability and that possibility that you can be symptom free if not symptom free, then significantly reduce symptoms to the point where it's something that you can totally live with.
Yeah, so true. For me, it's, going to pelvic floor PT, getting that pelvic floor dysfunction resolved or more functional, regulating my nervous system, getting out of that fight or flight has been a struggle, but we're getting there. And then like, yeah, little
Mhm.
things like you're saying, like making sure I'm staying hydrated, making sure I'm not like constantly wearing skinny jeans and tight pants, like not, poking the bear in a sense.
Right. And then that's what we help you guys do is to figure out your I don't really love using this word either, but I'm going to use it here like triggers. Like what triggers your symptoms to get worse? And things like even things like waistbands around the pants, it isn't because it's pressing on your bladder necessarily, but it's because it that hypersensitivity of your abdominal region because it's been in pain for a long time. It's like the hypersensitive car alarm. And so it's not the pants that are the problem, it's the underlying tissue there that's hypersensitive. And when we can start to address that, then sure, like we want to make sure that our pants aren't restricting the way that we're breathing and that, let's stack the cards in our favor to make it the best place possible for your little bladder and stuff. But it's addressing that underlying hypersensitivity problem. And we at the clinic, we do this a lot and with the we assess this a lot. And the way that we assess this at the clinic is what's in the research. And we use something called the Central Sensitization Inventory, the CSI. And it's a bunch of questions. And basically, if you score over 20, we have a nervous system issue, but really it's over 40 is in the literature to be something substantial where we know that there's a nervous system component to why your symptoms are upregulated. So we use that in the clinic a lot, and that's actually very in line with the three different phenotypes that the AUA has now recognized with there's lesions, which we talked about, which is one small subtype. And then the two other ones are pelvic floor dysfunction and central sensitization. And so that CSI tool can be really helpful to determine whether or not and how much your nervous system is playing a role in your symptoms. And sometimes it can be really eye opening because some of the questions on there are things like, are you hypersensitive to sound or any touch, right? Like, so it gives you some other indicators where it's like, oh, this is actually a widespread body problem, not just a bladder problem. And that can be really empowering for some people and it can give your pelvic floor therapist a good way to start to intervene that's in addition to the internal pelvic floor work that we do, right? So one of the big things for me too is that in order for you to fully gain back your life with IC, um, it's both internal treatment and external treatment. We've got to look outside the pelvis and we've got to treat the nervous system in addition to the internal work that we do.
Yep. Yep. We've talked about that so much on this podcast.
Cool.
So before we move into treatment and all that
Yeah.
conversation, one quick question about diagnosis.
Yep.
So there's a lot of people, who either ask me or they post in the Facebook groups, like, what about if someone has frequency and urgency but no pain? Like, do they technically fall into that IC diagnosis, or is it something else?
Technically, if you have absolutely no pain, then technically you shouldn't be diagnosed with IC, right? I would, like we said before a little bit in this podcast, I would like broaden the definition of quote unquote pain. So I would say that urethral irritation or that feeling when your bladder's like so full and it's really uncomfortable. Sometimes y'all get it when your bladder actually isn't full, but that discomfort could be considered pain. Lower abdominal aching could be considered pain. So that is one thing. The other thing, though, and this kind of goes back to the whole point of this little section of this podcast, is that we do know that pelvic floor dysfunction can cause urinary symptoms. So even if you don't have any pain, we know that pelvic floor dysfunction can cause urinary urgency, the feeling and the need to go to the bathroom, and frequency going to the bathroom a lot without that much put. And so it's like either way, and I know I'm biased because I'm a pelvic floor PT, but like either way, that's the play. So technically, I guess the answer is no, you shouldn't be diagnosed with IC without pain. But I think that if we broaden our, it doesn't have to be just urination pain either. It can be any sort of pain in the pelvic girdle, basically from your ribs down to your knees. So if you think about it like that too, sometimes people do have, they might not have pain with like the urinary symptoms, but you might also have hip pain, low back pain, lower abdomen pain, suprapubic pain, or pain right above the pubic bone. So that also counts. Does that answer your question?
Yeah, completely.
Yeah.
I think that'll clear some things up for some people.
Yeah.
So, in terms of treatment for interstitial cystitis and pelvic floor dysfunction, it brings me to this post I saw today in a Facebook group where somebody said that, what do you all think about pelvic floor PT? Is it a waste of time? My doctor told me it's a last resort before doing something super invasive. And I'm like, what is that doctor doing? Like, isn't pelvic floor PT like the first thing that is recommended, especially per the AUA guidelines, right?
Yes. This is like something I will scream from the rooftops. I will die on this friggin' hill. So here's the deal. So, and this is like, so the AUA guidelines were redone in May of 2022. Prior to that, there were these things called lines. And the first line of treatment was basically behavioral stuff, which was, oh, you know, fix your diet, do stress management techniques, whatever. The second line, which was basically the first line of medical stuff, was pelvic floor PT, and was a couple of other types of things. Pelvic floor PT has been given an evidence grade of A, meaning that if you look at the research on the efficacy or how well pelvic PT works, it has some of the best comes. And so that doctor that was saying that to that patient is totally wrong, not only just in the real world data, but also like if you look at the actual guidelines that they're supposed to be going through, it's a first line treatment and it's the one with the evidence grade of, and nothing else gets an A. Installations, Botox, like nothing else gets an A. No other medication does, right? Pelvic PT does. And it with the reworking of the AUA guidelines, they now did away with the lines and they just did categories. And so there's categories that are called behavioral and non-pharmacological treatments, right? Which physical therapy is in that category. And that's also where things like dietary changes are and stress management techniques and all of the things that you can and they call it like you're like teaching you how to pee and when to pee and all that kind of stuff, behavioral modifications, they call it. So all of that's in the first section. And then there's all the other medications and then procedures that you could do. Basically, like physical therapists and pelvic rehab providers are the ones that also can help you to know, should you be doing timed voiding or not? Should you be doing urge suppression training or not? Because there's a ton of people that just be with IC that just because you're going all the time, that is not appropriate for y'all to be trying to hold it for longer. That's just going to create more pain until we have your nervous system dialed in a little bit better or your pelvic floor muscles worked on a little bit more. And so that's frustrating to me to hear that that's still what's happening. Um, because that's not evidence-based. It's just not. And it's so that's one thing is that the urologist should be recommending pelvic PT early and often in the plan of care.
Is there anybody who PT isn't appropriate for?
It's a great question. The short answer is really no. The longer answer is obviously if someone doesn't want to go, then they don't have to. And I think the other misconception is that you have to get internal treatment. So I would say that if somebody has a history of trauma, especially sexual trauma, unfortunately, that is the incidence is high in our field with that. So I would say that sometimes internal treatment is something that we don't go to first, or we don't ever do if it's not appropriate for that person. Um, but we can certainly do a million and one things outside of the pelvis. But you got to get a good pelvic PT that understands the importance of both. And if you go to a pelvic PT that doesn't understand pelvic pain, there's a lot of people that specialize in pregnancy and postpartum issues and don't really treat these chronic pelvic pain issues that much. Right? So you have to really make sure that you're going to a person that understands chronic pelvic pain, understands interstitial cystitis, takes a full body approach to treatment. Um, but if that's the case, then there's really nobody that can't benefit from it, in my opinion. You just have to take in, well, what are you going to do with that? They're in that session. Are we going to do internal? There are some contraindications to internal treatment.
That's a great point. Because I do think there's this fear or just, fear of the unknown when it comes to pelvic floor PT about, there's people talking about what their experience is like in this internal work, and it can be scary. So I think it's good that you're saying that.
A couple more things I can say about that just to ease anybody's fears. I mean, number one, we're in this field for a reason. We know, we care, we've seen it all, we've heard it all. Like if you're nervous about the exam, just that's the first thing that you say on your paperwork. That's the first thing you do when you sit in this chair. You just say, I'm really nervous to be here. And we can totally talk about it and why. And we can decide together when it's appropriate to do that. We don't have to do it the first day. I mean, there's so many options. The second thing is that um, I feel like there's sometimes this phrase, and that doctor sort of used it, right? That it's invasive. And it's like what we do in our sessions is nothing like a gynecological exam. There's no stirrups, there's no speculums. It's just like a single gloved finger with a little bit of lubricant on it. And we just are looking at and we're feeling the tension in the pelvic floor. And it's usually on a nice table. It's not on a gynecological table. It's on like more of like a massage table. Um, Usually all of our offices are super like warm and nice, and we have salt lamps going, and maybe it's just like it's not like a gynecological exam. And I really want to highlight that for folks that are nervous about it, that it's so different. We get different information. And the fact is that very likely your gynecologist, your urologist, your urogyne has not done a thorough muscle exam of your pelvis. Even if they say your pelvic floor is tight, they have not done a thorough assessment like we would, and they're not finding why it's tight in the first place. And so that's our jam. That's like what we do. And so I think it is really important to talk about like what our exams like. And, we're watching you move, we're watching you walk, we're watching you do whatever you want to do. So if you're a weightlifter or you want to run, like we're watching you do that, and we're looking at your back and your hip and your foot and your sciatic nerve and your SI joint. And then we also happen to do an internal exam if that's okay with you. But it's not anything like a gynecology appointment.
Yeah, absolutely. So you mentioned your approach a bit earlier, but can you dive into like what a typical like patient assessment or what your treatment approach is for each person?
Yeah. So at Pelvic Sanity, and this is what I teach. So I teach this to clinicians as well. So I think still I'm the only pelvic PT that actually has a clinician-based course for other pelvic floor rehab providers to learn how to treat this condition in a holistic manner. So it's basically a little bit of what I just described. It is we take a very thorough history of not only when did your IC symptoms start, but when did you first have signs of pelvic floor dysfunction? And that's where I think sometimes a lot of people will say, well, I started to have my IC symptoms, for 5 years or whatever. And then it's like, if you actually take a look even before that, we had signs of pelvic floor dysfunction brewing even before that. And that's not to scare anybody. That's just to get the full picture of what we're actually looking at and what we might have to look at in the exam. So for instance, just to give you guys one example, one of the big things that we talk about or one two things really. We look at your history of your menstruation and do you have painful periods and things like that, because we're also thinking about how endo and interstitial cystitis can be go hand in hand. And while endo isn't only painful periods, it certainly is like an indicator that we're like our little antennas are going up to be like, could this be that? And also, we're looking at things like low back pain and tailbone pain. Did you ever fall on your tailbone even when you were a kid that you remember? Things like that can set your nervous system up for tensing and protecting the pelvis and pelvic floor, and that can set yourself up for pelvic floor dysfunction. It's also an interesting statistic that 95% of people with low back pain also have pelvic floor dysfunction. So I'm also looking at, have you ever had low back pain? Even one bout of it that was pretty bad? Have you ever had hip pain? All of those things can actually make your pelvic floor compensate for when that was hurting. And that sets the stage essentially for your pelvic floor muscles to be sort of on guard when they should just be sort of chilled out. And then, put in one stressful event or something that sort of kicked you over the edge to start to have these IC symptoms. That's when your pelvic floor was finally able to like not compensate. So in terms of the exam, we talk a lot about your subjective history. We talk about your bowels. We talk about your sexual history and health. We talk about if you've had babies, we talk about how those births went because whether you had a C-section or a vaginal delivery, that can create pelvic floor dysfunction as well. If that, if you tore or even if you didn't, that's just a challenging time for your pelvic floor. And then we do an external evaluation. So that's where we look at your low back, your hip. We ask you to move. We look at your SI joint. We look at your hips. We look at even sometimes all the way down to the ankle. And then if we decide both that will be a good time to do the internal assessment, we can do an internal exam. We look all of the pelvic floor muscles. So the ones that wrap around the urethra are in the superficial triangle called the urogenital triangle. So we look at those muscles. And we also look at the deeper levator ani muscles, which are more of like those Kegel muscles that you're probably more aware of. Those ones are the ones that attach all the way back to the tailbone. And then we kind of at that point are like, okay, like what do we think is going on? And then we kind of create a treatment plan based on that. We look at nervous system function, we do the CSI, and we sort of just get like a really holistic approach for what might be going on physically. And then we also take a look at I know that you're an expert in this, Callie, but we take a look at all of are you food sensitive? If so, when? And then we decide when to tackle that. For most folks, we actually tackle that later. We're really a more of like a nervous system, get your nervous system dialed in, get your pelvic floor symptoms better so that you can better tolerate the foods that you're putting in your body.
Yeah.
Um, yeah, so
That's
go
a
ahead.
Yeah, you saw me just start to talk. Sorry.
No,
That's
go
a
for it.
great time for me to insert this comment slash question. So a lot of people and myself, I'm included in this, notice that when their symptoms are at their worst, so is their diet sensitivity. And then over time, as you start to figure out your root causes, you treat everything, you can eat and drink more and more as you go. For me, I used to be really diet sensitive. Now I can have whatever I want. Is there
Yes,
any like science behind that, any research that supports that? Like, do you know what I'm asking?
I do. I think that if you're saying, like, is there, yeah, I get what you're saying. I don't think there's any research that specifically says, oh, when your nervous system gets better, are more able to tolerate foods, right? But we do know from some great research that while the majority of people do report some diet sensitivities, I think it's up to 90% of people will report that something bugs their bladder, right? But, and this is a huge but, if you actually look at the raw data in some of those studies, the average person with interstitial cystitis only has 5 to 7 trigger foods. Crew foods that are consistently like, "Ah, darn, like that really does bug me." So what we talk about at Pelvic Sanity is this concept of building resiliency in the system. And so if you think about like where the symptom threshold line would be, then where a lot of people come into pelvic therapy is right hovering over the line or well above that line, meaning that anything that you eat is going to produce symptoms because really anything is going to produce symptoms. And I think the easiest scapegoat is to say, oh, it was because of that blueberry or that whatever. So, but the more that we know about the condition, when we know that it's not a bladder problem, and I think this is where a lot of the misinformation came from. We assumed for 20 years that it was a bladder issue. We now know that it's not. And so, but I think that there's a lot of misinformation around that whole concept of what causes IC. And so when we assume that it's a bladder condition, we think that anything that we eat is going to increase symptoms. What we fail to also think about is were we stressed out at that time? Is our back hurting also? We forgot about all the other confounding issues that we are also, but we're just like hypersensitive or hyper focusing on the food problem, right? So what we talk about at Pelvic Sanity is like, my goal for you is to be able to do exactly what you've gotten yourself to be able to do, Callie, right? Is to eat or drink anything. And even if you happen to have a little blip of your symptom go up, it's like no big deal. It goes up, it's a little irritated, you're annoyed for a second, but that piece of pizza or that thing that you ate was like super awesome and great and you were doing it with your friends or whatever and it's no big deal. It doesn't create a whole cascade of negative events afterwards. Like that's my goal for literally everybody. And the majority of our patients have been able to get to that point. And it's because if you build that resiliency so that your pelvic floor isn't bothering your bladder, if your nervous system is calm and isn't bothering your bladder, if your inflammation is down and it's not bothering your bladder, if, all of those things are happy and healthy, then you can have a little bit more tolerance for something that actually may cause you a little bit of a problem. And so that's where I really am like passionate about. I feel like so much we pathologize eating food. I've had people that have had eating disorders specifically because they're restricting their food so much, and it was never about the food. And that's sad because now we have a whole other issue to deal with that wasn't really the root cause in the first place. And so I know I'm preaching to the choir here, Callie, but like that's what I want everybody to sort of like understand is that, and it's not only just me saying this. So you asked about, is there any research? And I would say that the research is that we know for a fact, like 25 years of research, that it's nervous system driven and it's pelvic floor driven for the vast majority of people. And the fact that we know that means that, we also know that it's not all about food.
Oh my God, I'm so glad you're here because I'm saying this every single day in my social media content, and like to have you back me up and saying all of this
Yeah.
is amazing. Like that validation is amazing. I am so sick of people blaming food. Like it's not anyone's fault by any means. It's just me as an IT dietitian. I know that most people really aren't as diet sensitive as they think they are, if they even are. And it's
Right.
like the food fear that has been produced is out of this world, in my opinion. And it's such a shame. And I think having these conversations is so important, and talking about discovering the root cause, and like just I think this conversation is amazing. That's the point that I'm trying to make.
Yeah. Well, and I just feel like I just feel like and I can understand why. I'm not saying that people's symptoms aren't real, right? I'm not saying that someone that comes into my office that says, "I'm super diet sensitive," I believe you, and I understand your lived experience that is when you eat whatever it is that your triggers are, you have more symptoms. What the point being is that why is that happening? And the majority of people, it's not because there's anything wrong with your bladder, and it's not because anything is bad about that food. And in fact, a lot of the things that we end up doing when we actually do, and I know that you do this too with like you help people through an elimination diet, when we're going through that with folks, we actually start to symptom log and symptom track, and we find that the thing that they thought that was a trigger actually isn't. It's something else that they're just happen to not be paying attention to.
Mhm.
Um, and it can be really empowering that way to be like, whoa, it's not that. It's when I was dehydrated because also when I was eating whatever it was, an orange, then it was also at a time when I was lacking hydration and I just finished, a really big project at work that I was super stressed out and I got in a fight with my significant other. And like the food is always the easy thing to point to,
Mhm.
um, because it's the easiest thing to see until we actually really do a deep dive into everything. Or it was a time when you were constipated and sure you ate that thing and it created more pain, but it was because you were constipated. You hadn't pooped in 3 days. That was what was creating the bladder problem. So I think that when we can talk like this and really start to not pathologize the food in the situation and just use it as like um, ooh, we're like hovering right along the line there that we need to far below it so that we can eat whatever we want and have a good life. Like that's what we want to do. And for all of the people out there that are restricting their intake and stuff like that, like I get why, but that's why you got to work with somebody, public PT or someone like Callie that understands this, that can help you and help you to add back in foods for everything that you take out. So for anything that's a trigger for that we find, I say, okay, well, what's something that we know is safe that you're going to add back in to your diet as well. So it's not that we're restricting everything, but it's like we're trading stuff. Because and we have a list of safe foods that you can eat, that if you're in a flare, like you have it, right? And so it's I think a really important piece to the whole nervous system regulation also because if you're freaked out every time you put something in your mouth, does not do any favors for your autonomic nervous system, right?
Definitely. It feeds into that. I think it's called the pain anxiety. No, wait, fear anxiety cycle.
Yeah,
No.
fear, anxiety,
Yeah.
pain cycle. Yeah, yeah,
Yeah.
yeah, yeah. And in
Um,
the book, I wrote the book called The Interstitial Cystitis Solution. And in that book, we talk about the DIP cycle, the dysfunction, inflammation, pain cycle. So if you eat a food that happens to be inflammatory for another reason for you, it doesn't have to be because it's acidic or anything like that, then we're increasing the inflammation response. That can create more pelvic floor dysfunction, which creates more pain, which creates more inflammation. And now we're in the cycle. And so now even something, that normally wouldn't bother you, but now does, it's because that system's hypersensitive. And I want you to go back to think about that car alarm, right? That's overly sensitive. That's what the inflammation, the global inflammation stuff does, which is why I feel like movement is so important and getting the right amount of sleep and all of that stuff is super important for the global inflammatory state that your body's in when you're in an IC state.
Hmm. Yeah. And while we're on the topic of diet, I mean,
Yeah,
I was just listening to you do this podcast with someone else. I completely forget the name of it, but you were talking about busting the myth of the icy diet. And it's like that
yes.
is so true. Like there we have this icy diet, but the research really isn't there. The quality of that research. Do you want to kind of talk about that a little bit?
Yeah, absolutely. So one of my big things is that I want to scream from the rooftops that the phrase "IC diet," and I put it very much in air quotes, does not exist. There literally is no such thing um, called the IC diet. What happened was actually a interstitial cystitis association, which was trying to do a really great thing, basically pulled all of its constituents and got, I think, over 350 or around that amount of people that just all it was a survey. It was literally just a survey that was like, what flares your symptoms?
Was this the Long Island University study or is it a different one?
Believe it's a different one.
Okay.
But basically, it was just like, what flares you? There's no control group, there's no it's literally just self-report, and for all of the reasons that we just stated, like, where things can be, um, correlative for that person, or you assume that it's that why you had those symptoms, but it's not really the food, like, you're just basically getting a self-report of patient's symptoms. So, they put a big list together, and they did find some correlations between certain foods, and so if a lot of people said it, they put it on the red list. If a medium amount of people said it, they put it on the yellow list, and then if they not that many people said it, they put it on the green list. So that morphed and just kind of went rampant, and then the people took that as, "Oh, I can't have anything on the yellow and red list," and that is just there was no evidence to support that. This was all back when we were first starting to really understand pelvic floor dysfunction and nervous system stuff, and so there was still, like, a little bit of a bladder-centered, approach to treating IC, which now we know has been sort of debunked by the latest really big studies through the NIH and the NIDDK, and so what what came from that, though, is people searching IC diet, coming up with this massive food list, and people freaking out that their life was over, right? I remember treating people when this was a big thing. People would come into me with this big, long list, and I would be like, "Well, all of my patients that get better can eat everything on this list, so what gives?" And so I think that it's important for us to know now, like what I said before, there is a high incidence of people that are diet sensitive to some things, but the list is small, 5 to 7 on average, and most people can end up tolerating a lot, if not everything, that they want to eat. There are, and this is conflated too sometimes with things that are like known bladder irritants. So that is not the same as interstitial cystitis like issues, right? So we know, for instance, that caffeine will increase urine output. It's a diuretic. We and a bladder irritant. We know that um tomatoes, citrus fruits sometimes can irritate the people's bladders, but it's not because they're acidic. It's not because of anything like that. It's it for various reasons. They can be histamine releasing. They can be for there can be a lot of different reasons why that food creates urine output, right? And so that's one of the things that I feel like is one of those things that have gotten conflated over time in Facebook groups and stuff like that, and it's hard to combat that misinformation. Um, and again, I don't wanna discount anyone's lived experience, like, I get it, but I want people to also understand that there is a way out of that, and it's decreasing the sensitivity of your overall system with nervous system stuff, with pelvic floor stuff, with stress management, with sleep, with all of the things so that the food isn't the thing that pushes you over the edge.
And you wrote a really amazing blog post about busting the myth of like acid in versus acid out. Do you want to talk about that? I know we're getting to the
Yes,
end of time, but
I
I
would
feel like you
love
were
this.
very passionate about it in our pre-podcast conversation.
Yes. Okay. So here's the thing. There, there's so much talk about acidic foods being the devil, right? And so not even taking into account all the things that we just talked about, but like, even if you're still like, Nicole, I'm not sure, I still think. So that blog post article that I wrote was all about like, just like the actual physiology. Okay. Our system is really good at making sure that anything that we ingest does not increase or decrease our blood acidity level, right? We are at a very stable 7.4. And in fact, if we go too far one way or another, we're in like the emergency room, dire straits problem, right? Our bodies are meant to create this homeostasis, and the blood level of our or the acidity of our blood, it matters a ton. Because of that, when you ingest something that has a certain property to it, our bodies are doing all kinds of stuff to sort of neutralize that. And so by the time the stuff that gets to the bladder is in our bladders, it's very much on one side or another. So even if you don't want to believe me that that's just biochemistry wise, acid in doesn't equal acid out. But they've actually done studies on this to show a couple of things. Number one, keep normal populations and people with IC, their urine fluctuates in their pH throughout the day. Sometimes it's a little bit more acidic, sometimes it's a little bit more basic. And so if it were true that acid was the problem with interstitial cystitis in the bladder, then we would see a very direct correlation between high acidity or low acidity in the low pH, high acidity of the bladder with symptoms, right? It would be directly proportional. And we just don't see that that happens. They've done studies where they have taken out urine, they've changed the pH and instilled it back into an IC patient, and the symptoms were not correlative with the amount of with the pH of the urine in there. So we know that not only is it not so simple to say acid in equals acid out, but even if that were true, it still is not what we physiologically have seen in the research. And so that's just one more tick on the box of it's not about the freaking food. It just really isn't. And I feel like if we look at it as a big picture, if we weighted all of the things, it's so much more important to look at pelvic floor, nervous system, sleep, movement, stress management, all of those things. And then food then is just the little icing on the cake, right? And so it really is important to understand that. And I'm not saying that changing your diet isn't important, because we do know inflammation plays a huge role, and so we do know that there are foods that are more inflammatory to the system than others, but it's not about the acidity of it with people with IC. We want to create a food intake that is healthy, non-processed, like all of that kind of stuff. And that's why it's really important still to pay attention to diet, but it's not usually for the reasons that most people with interstitial cystitis think it is.
Yeah. Yeah, absolutely. I think that was really well said. I agree. I did really want to talk about your book, but we are out of time.
I have a bit more time.
Oh, okay, amazing.
Yeah, we're good.
Yeah, you want to just quickly talk about, what made you want to write the book? It's called The
Yeah.
IC Solution.
Yep.
And
So
I
it's
feel
called the
like it
interstitial.
performed so well, and I read it and I loved it. So yeah, please talk about it.
Totally. So I wrote a book called The Icy Solution, with a nudge with my husband. So my husband used to be in the medical research field, and so he was like, "Nicole, you got to write a book," because I would come home all the time and just be like, "This is so crazy." One of the reasons why I called my clinic Pelvic Sanity was like I was treating all these IC patients, and I was like, "This is so insane! Like I'm seeing such different results than what I'm seeing online." And so I was like, "Well, let's put my money where my mouth is. Like, let's write positive, practical, evidence-based summary of the condition. And at the time, and it still is true, I believe. There's a couple of other books that have come out, but at the time, Dr. Moldwin's book um, was 20 or 25 years old. And we had learned even a ton from when he wrote his book. And so I was like, there's no one that's writing anything that medical about this. There's a bunch of like patients writing books, but sometimes that can get a little bit funky with just their lived experience is different for everybody. And so I wanted to write a book that was positive, practical, had evidence-based information. It was written for patients or people that have suspected interstitial cystitis or bladder pain syndrome. But I wanted it to also be um, medical enough so that another practitioner could read it and be like, oh, there's actual evidence behind what she's saying and stuff like that. The main goal at that time was to give a big overview of the condition, bust the IC myths, figure out like what should everybody be getting. One of the biggest things that I was a proponent of, obviously biased a little bit, was pelvic PT, that it was supported by the literature at that time. But what happened there is that I had a ton of people write me and say, "Hey, I've been to pelvic PT and it's nothing like you describe in the book."
Mhm.
So then that leads me down a whole nother road, which we can talk about just briefly here in a second. But so that's one of the reasons why I wrote the book was because I wanted to get the word out, the positive practical information about this condition, where the science was, where the research was, because a lot of things that I was hearing from patients was also that like no one's researching this condition. And I was like, actually, on the contrary, there's been a ton of research done about it. We know now what truly causes interstitial cystitis. We didn't know 20 years ago when we basically know now. And so that was really, I think, a powerful thing to help people to see. It's sold 20,000 copies. It's just done really well. And I think it's because it's in a very accessible format. It's not super medical. The information is good, and there's just some really good practical takeaways in each of the sections that is really helpful. There's stretches in there. There's symptom logs. There's things to talk to your doctor about. There's medication lists. There's all kinds of stuff in there um, that can be really helpful to someone on this journey.
Yeah, I think it could be helpful for someone new to the condition, also like an IC veteran. I thought it was really
Yeah,
great. And
awesome.
you were going to say something about people who are reading it who maybe they didn't have the same PT experience that you're describing.
Yeah, and I run a Facebook group as well, just like you're a part of as well. And I think that overwhelmingly, the really frustrating thing for me is that people will go to a pelvic floor PT and they'll be like, they told me to do Kegels, they did biofeedback, and I'm not better. And that pelvic floor PT doesn't work for me. It must not be pelvic floor dysfunction. And I just want everybody to understand that just like any any other profession, there are good, there's bad, and then there's just neutral people that are, maybe not as passionate about something as somebody else, or maybe they love treating pregnancy and postpartum and you just weren't their person. I really want people to think about pelvic floor therapy like they would their hairdresser, right? If I went in and got a bad haircut, I would not say the conclusion to that bad haircut would not be like, I'm never cutting my hair again. This is terrible. This is not the way to go, right? I would say, man, that hairdresser sucked. She didn't listen to me. That was not that's not the right cut for my face. Like I don't like what she did. I would just pick another hairdresser, right? And that's what I want for everybody is that if you didn't get good results with a pelvic floor therapist, I would highly encourage, if it's possible at all, to just try another one, try and try again, get a second opinion. There's many of us that are doing remote consultations online that can help you to find a good person in your area. Um, there's more and more people every day that are taking my course, for instance, and like getting educated about it. And I just want to make sure that we don't, the conclusion is not pelvic PT didn't work, but it's like that therapist was not the right one for me. Um, because I'm really just passionate about that. We've seen that time and time again. Like people that come to pelvic sanity, there's 70% of the people have seen other pelvic floor physical therapists without getting relief. Like it's a thing that we're not all created equal. It's a sad reality. It is getting better though. Like there are more and more people going to this into this field. People are excited to help people like you guys. And so I would always make sure to just do a Google search, check our practice. We have a practitioner map um, as well that we can link in the show notes of, it's not necessarily people that have taken my courses, but it's people are popping up all the time. New pelvic floor therapists, occupational therapists can actually do pelvic floor rehab. And so I would highly encourage you, especially if you like had pelvic PT, didn't work, um, check again. Maybe there's someone else new in your area that's popped up. Sometimes it's good to drive a little bit of time to get a second opinion. There's just so many options, and I just don't want people to think that just because one experience was not great, that it's you should just like forget about it all.
Yeah, 100% agree. I'm on my fourth pelvic PT now, and it took me
Yeah,
that long to find somebody that I
totally.
vibed with. Yeah.
And for the love of God, if you're doing Kegels, stop. And if you've been told to do Kegels by a pelvic floor physical therapist, you better have a freaking great reason why, and your symptoms better be getting better. Because the most frustrating thing and the most common thing that I've seen is people are told that their pelvic floor is weak and they need to strengthen it. And once they do, their pelvic floor dysfunction will go away. And that is not best practice for somebody that's in pelvic pain. So when you have pain and your pelvic floor muscles are already tense and overactive, or you don't have pain, but they're just tense and overactive from external stressors, and your nervous system is holding pain there or holding tension there, it's not a thing to do to contract that more. It's just not. I will die on that hill too.
We're
And
dying
I
on a lot of hills today.
a lot of hills. But like it's just not best practice, and it's specifically in the AUA guidelines to not do that. And so we need a different approach. And here's the thing, this is the last thing I'm going to say about this before I get off my soapbox or on my hill or whatever we're on. But it does not mean that pelvic floor strengthening is not good for you, right? Sometimes we do need to pelvic floor strengthen, but we can do that without Kegeling. We can do it without Kegels, okay? And so that's where I really need you to go see a pelvic PT that understands the whole system, that can really be very specific on the things that you need to be doing in order to get that holistic approach to your symptoms.
Definitely. Okay, we have died on our final hill. Do you have anything else you wanted to say before we wrap this up?
Well, Kelly, I just really thank you for all the work you're doing in the field. Honestly, like this has been such a pleasure to be able to talk with you. Thank you for inviting me on the podcast. And I just really want people to know that, there's a quote in the book. I said, thousands of people live happy, healthy, pain-free lives with interstitial cystitis, and so can you. And I truly believe that. I believe that healing with this condition is not only possible, but it's probable with the right medical team. And I really encourage all of you to get good, positive, practical, evidence-based information from people like Callie, from people like me, and spread the good word. Once you start to do better, once you get your medical team in place, and you can be that sense of positive light for all of the others that are also struggling.
Yeah, absolutely. And I'm going to link all of your, website, social media in the show notes. And then if you guys are getting sick of listening to me or you just want somebody else in your life, Nicole, you just came out with a podcast for patients, right?
I did. Yeah, I've been doing a practitioner focused podcast for a long time now, which is great, but not really appropriate for people that have any sort of pelvic floor thing. But now I do. I have a podcast for patients. It's called Finding Pelvic Sanity. We also have a Facebook group where we monitor quite heavily to make sure it's positive, practical. People don't go off the rails with stuff. And it's called Finding Pelvic Sanity as well. But you can join us there and listen along. And we do a lot. We do all pelvic floor dysfunction, but we obviously do a lot on IC because it's one of my biggest passions.
Amazing. All right. Well, thank you so much for your time. This is amazing. I'm going to shout about this episode from the rooftop. But yeah, thanks for all you do, Nicole.
Thanks so much, Callie. Really appreciate you.